Good afternoon, dear colleagues, friends, ladies and gentlemen. It's a real pleasure to welcome you to another series of these exciting PCR educational webinars, today entitled The Expanding Practice of Left Atrial Appendage Occlusion, today in case examples. Now, the learning objectives of today's series are to understand about current indications for left atrial appendage occlusion in clinical practice, to appreciate unmet needs and scientific gaps in evidence to optimize patient care, and finally to learn about future indications of left atrial appendage occlusion with critical reflection of existing evidence. And my name is Michael Jona, I'm from Munich, Germany, and I'm thrilled to have an amazing faculty with me. To my left is Professor Boris Schmidt from Frankfurt, Germany, Cardiovascular Center, and to my right is Dr. Matthias Lange from Osnabrück, Germany. Both welcome very much. We'll have a very exciting discussion, and I would like to start just introducing into the topic by showing you this slide, which is all what it is about today. On the very left end of this arrow, you can see very early studies that investigated left atrial appendage occlusion in a setting where patients had I would say, relatively strong contraindication to receive oral anticoagulation, be it patients that had prior bleeding or others. And as we move along this arrow to the very right end, you can see patients that are actually good candidates to receive mid to long-term oral anticoagulation. And there's frequent discussion in the cardiovascular community whether these are appropriate indications and whether this is supported by data. So today we have chosen a case-based approach where we'll show you two cases. One which is reflecting more contemporary practice, showing a case that has a clear indication for left atrial appendage occlusion, and another case that is maybe going beyond and showing you some of the future indications that could be relevant. Without further discussion, I would like to start with the first case and hand over to Dr. Matthias Lange to present this case.
Thank you, Michael, for the kind introduction. And I want to present you a case today of an 82-year-old woman with paroxysmal atrial fibrillation. She was admitted to our hospital in the beginning of September this year because of a subacute intracranial hemorrhage. And she already had suffered from an intracranial hemorrhage before in 2006. She also had a history about ischemic strokes. There was one ischemic stroke in June 2024 and an older one in October 2020 already. She also had a coronary artery disease and arterial hypertension, and this long history of the patient sums up to a CHA2DS2-VASc score of 6. So there was a clear indication for LAA occlusion. And I want to start this case also with a TOE picture. And you see this picture and you're used to decide, whether it's a broccoli or windsock type and all the different kinds of names you can give to the left atrial appendage. But the really important point is when you look at those pictures is to look for anatomic risk factors for a device-related thrombosis or peri-device leak or even embolization of the device. And there's a new LAAC classification published this year, which points out those anatomic landmarks that can lead to problems. You should look at the ostium. If it's a real large one, you have a higher risk for PDL. You, of course, have to look at the pulmonary ridge. If the pulmonary ridge is very long, there could be an issue between the angle between the disc and the ridge, which has a higher chance for a DRT. Of course, you're looking at the landing zone, and the eccentricity of the left atrial appendage is a really important topic because you usually have elliptical shape and not a circular shape. And you should look for a proximal bifurcation, because a proximal bifurcation, what you probably see only in 135 or 150 degrees, could resume in a very small landing zone. Those are issues to look at. Also, to look at whether there's a sharp bend of the left atrial appendage. Of course, you have to consider the axis to finally get a coaxial implantation of the device to avoid PDL. And if you have a sinus rhythm, you probably have a hypercontractile left atrial appendage, and this is probably an issue to implant the device a little bit more distally. But coming back to our female patient we are talking about, there's an LAAC score of about 0, so it's supposed to be an easy, straightforward case. So in this slide, you can see the measurements you should perform. You should measure the landing zone, 10 millimeters small for smaller device, 12 millimeters for larger device if you are going for an amulet device to get the right measurement. But when you measure in a TOE with 135 degrees, you probably miss the largest diameter, and this is what this slide is all about. The recommendation to do a 3D TO, or even if it's available, a CT scan, is to make sure that you have the real maximal diameter. And in TOE, the maximal diameter is often in 150 degrees. What we did in our patient is a 3D TOE with flexi-slice, and we had a maximum diameter of 18.2 millimeters in the landing zone. And as you can all see, it's more a circular-shaped left atrial appendage landing zone rather than an elliptical one. So looking at this sizing chart for amulet devices, you end up with a 22 millimeter device, probably a 25 if you go for a little oversizing because it's a circular landing zone. If you wouldn't have had a circular landing zone, this other sizing chart, which was published 2022, could be taken into account. And as you can see, if you have a very elliptical shape of the landing zone, you should not pick a huge device. You probably take the maximum diameter as a device size if it's really elliptical. But coming back to our patient, even in this chart is a 22, but we finally decided to take a 25 millimeter device because we thought probably we would end up a little bit more proximately. And as I already said, and if you have a circular landing zone, you can go for a little bit oversizing of the device. So this is the TOE picture, the ball configuration, as you can all see, one step in implanting the device. And the ball shape is below the circumflex artery. It looks pretty good. So we released the first part of the amulet device, the lobe. And as you can see, it's 2/3 of the device are below a circumflex artery. And once we release the disc, you can see that the disc is below the ridge. And when you see this situation, this is a situation where thrombus can occur pretty often. So looking at this study, Eurointervention 2021, that was shown nicely when you have a coverage of the pulmonary ridge, you have a very low DRT rate of only 1%. So this should be the goal. The goal, if you have the close criteria all fulfilled, to get the disc as proximal as possible to avoid this situation of the device thrombosis in this angle between the pulmonary ridge and the disc. So when you look at this, at these pictures, you can see what we did. We did a tug test, but when you perform the tug test, you have to perform it real gently. That's really important. But even with a gently movement, you can get a ball configuration of the disc, and then you push back the catheter to achieve a concave situation of the disc. And as you can see, the closed criteria are still fulfilled even in this situation. So it looks like a stable situation. This is the fluoroscopy of the procedure. You can see the gentle pull. I say it again, it's important. And there's a small ball configuration, and then we were above the ridge, and then we pushed back the disc. This is a final tug test, actually. You don't have to do it if the close criteria are fulfilled, but we still did it. And in this echo, you'll see the release of the device, and it even kind of tilted in an even better position after it was released from the cable. This is a final angiogram. Thought a pretty good result with the disc above the ridge. And of course, before we released the device, this is afterwards, we ruled out a peri-device leak, very important topic. And you have to look at the Nyquist range in this echo. It has to be in between 20 and 40 centimeters per second that you can detect the slow flow as well. This is the final 3D echo, and this is the last slide of my case.
Thank you very much, Matthias, for this excellent case. I think well done. We all know that this gentle pull sometimes is not so easy to do without risking embolization, but this was perfectly done. Now, all of these questions that we have centers around the topic of peri-device leak and device-related thrombosis. Maybe 10 years ago, we didn't focus so much on that, quite honestly. But these days, we know we have data showing that this is a risk to our patients. So you have also brought some additional slides that guide us in this discussion because we believe this is extremely important. So what can the interventionalist do before the procedure to get a better risk stratification, whether this will be a high risk for peri-device leak, for instance?
You really have to look very well at the anatomy with the echo, or if available with a CT scan as well. And if you have an eccentricity, as you can see on the left side, you really have to avoid undersizing of the device. As you can see, if the device is too small, there will be no embolization of the device, but there will be still a peri-device leak. This is a situation you really have to avoid. Irregularity in the landing zone is more common than you think. So this is an appeal to the imager to give a good picture of the landing zone. And you can probably avoid this situation in the middle by using a lobe and disc device to cover the ostium and to achieve a coaxial implantation of the device is always important, especially when you use a plug device like image on the right side.
Yeah, excellent. That brings me actually to a point, Boris. We have the exceptional situation that we have different perspectives because you're an interventional electrophysiologist and structural interventionalist. What thoughts come up in your mind? Is this something relevant before you do the procedure? And would you make a choice of device based on these kind of things that we've seen?
Yeah. Oh, yeah, that's a very important question. First of all, I want to congratulate you for the case. It was really perfectly done. But it also showed that finally the position was a little different from what you expected and when you measured the landing zone. And this is not because you're measuring wrong, but sometimes it's quite difficult to predict where the device will end up. And fortunately, you decided to go with a bigger device, so you had a perfect sealing. And I think there are two approaches to this very important topic. The first one is procedural planning. One can do CT scans, one can do 3D modeling, simulation models, etc., which might be a good approach for this. But in my opinion, it adds a lot of complexity and may exclude certain operators in certain centers from these approaches because it's a cost factor. Mm-hmm. The second approach would be to improve the devices. My dream has always been, I want to have 3 different devices, small, medium, large, and they should seal all appendages and make it easier for the operator to occlude. And I think companies have made a large step forward with new devices that will come with more conformable lobes, occluding more of the left atrial appendage.
Yes, very good points. And Matthias, I think you brought also some additional long-term data, which is extremely important to see long-term data. And we have data from the randomized AMULET IDE trial. You want to quickly give us your thoughts on these data?
Yes, it's a comparison of the most commonly used devices, the AMULET occluder and the Watchman device. And you already mentioned it, those are the 5 years results of this comparison of those two devices. And as you can see at the top on the right side, it looks pretty similar. Looking at the stroke rate, looking at the bleeding rate, cardiovascular death, pretty similar in both groups. But when you look at in the details, and this is what you can see on the bottom of the slide, in the Watchman device group, there were more patients on oral anticoagulation after 5 years. So this group probably has more bleeding complication. There was a similar stroke rate per year, and the number of fatal or disabling strokes was higher in a Watchman group, and this was probably due to a higher rate of DRTs and a higher rate of PDLs. And as you can see at the bottom, there's almost double as many of those events in the Watchman device group.
That brings me to an important topic, which is one of my favorites, but there is not a solid, clear evidence, at least, boys. Do you think there's an association between peri-device leak and device-related thrombosis? And I'm advancing to another slide that maybe give us some hints in this regard.
Yeah, certainly. I think Matthias already elaborated on the LAAC criteria, and I think the device positioning and the level of closure certainly plays a role. We can see it also from this data that the dual seal occluder had better rates of complete sealing of the left atrial appendage. So this is, since we know that peri-device leaks, at least those that are bigger than 3, maybe even the smaller ones, are associated with thromboembolic complications, it's a favorable event. And to be fair, the Amulet IDE study compared the Amulet device towards the 2.5 generation Watchman. Now, also, this company has already made progress with the Watchman Flex and better sealing rates. So that was an important finding for this study. Coming to device-related thrombosis, yes, we learned that the deeper implantations are associated with more thrombus. And in this particular sub-study, Jens Erik Nielsen Kutz from Denmark found that DRT is not DRT. We have separate groups. We have the ones that are just layering on the disc or on the surface of the device, and those that are pedunculated and are prone to embolize. And this is something that we need to tell our cardiologists and echocardiographers that we need to differentiate between the two.
I think it's a very important point, because when you look at the individual patient, you want to kind of judge the personal risk. If somebody has a DRT, which is not really, which is about 3 or 4% of all patients still, so it's an issue that everybody is facing with. And when you look at the study again, there's a mobile thrombus, pendicular morphology. Those are all hints for a high-risk thrombus. So this is probably a patient you would start with anticoagulation, definitely would start with anticoagulation again when you discover it in a TOE, although you probably had a history of a bleeding event.
Yeah, that's a very important point. Let's stay with this point for some time, at least, because I think this is very interesting to the audience also. How would you specifically deal with this particular patient that you have introduced? Because he had prior cerebral bleeding, high CHA2DS2-VASc score. So let's assume this patient comes back and has a DRT. How do you deal with this patient?
That's a very good question, yes. As you already saw, it's a really high-risk patient, history of 2 intracranial bleeding, but on the other hand side, a very high stroke risk, because she already had 2 ischemic strokes in history. I would really look at this slide again, and then I would, if it's like a small thrombus lower than 3 millimeters, I would be a little bit more conservative and probably do a dual antiplatelet therapy. But if it's a high-risk thrombus, I would definitely give a DOAC, definitely.
Okay.
But probably a low-dose version like apixaban in low dose. This is a good compromise. And we observed that DRTs are in regression under apixaban in low dose.
Interesting. Boris, what's your take on this?
I totally agree. So I think aside from the bleeding risk and the thromboembolic risk, we should also look at the time point where we find this DRT. How long have we been giving the device to heal? How far is the endothelialization? But obviously from prospectively randomized trials, such as the ADALA, we have learned that the low-dose DOAC therapy seems to be associated with the least number of DRTs and the least number of bleeding complications when we compare it to dual antiplatelet therapy. The question is, of course, how long do we do this in this particular high-risk patient? Do we do it for 3 months, 6 months, 12 months? I think we don't know for now. And we would need to schedule more TE follow-ups in the future.
Yes.
Yeah.
Yes.
Excellent. I want to use the opportunity and also encourage the audience to send in Q&A, send us questions. So we will try to interact with as many as possible during the session. One of them has come in already, and this is dealing again with the imaging methodologies. So what imaging strategies such as TOE, ICE, or CT planning has been impactful on reducing complication and improving the quality of left atrial appendage closure? Maybe I hand this to you, Matthias.
Yeah, sure. The CT scan is a really good method to plan your procedure, definitely. In our hospital, in our institution, we don't do it regularly. We trust on 3D echo, but it's a really good possibility to do a planning of the procedure, that's for sure. When you use a TOE, you always, if it's available, you should use 3D TEO. I already showed the picture of the flexi slice. You can do, I think this is the most important issue of the 3D echo. It's even more important than the 3D view. It makes nice pictures, but you measure in the flexi slice.
Yeah. Boris, what can the CT give you in addition to the TOE for pre-procedural planning?
Yeah, I think it's a very elegant method. However, depending on geography, it's not reimbursed. And this is a hurdle for an obstacle for many physicians to employ it into their standard workflow. First, we have to say that within the randomized studies, Option, we mentioned it, Amulet ID, we mentioned it, the implant success rates were very, very high, well above 95%. So obviously we can do it without CT, also in a safe fashion. However, if we broaden our operators and go into the field, then we can see from US registry data that CT has some additional benefit for procedural planning. Number one, it decreases the number of devices you need to successfully close the appendage, so missizing is reduced. And then there was also a favorable trend towards reducing complications. Yeah. So I think for less experienced operators, it's a very valuable tool in getting prepared for the procedure itself.
Let me push this even a little further. I mean, as you are doing a lot of AFib ablations and other electrophysiology procedures, oftentimes I see that pre-procedural CT or MRI planning is being done for this. Is there a chance in the future we can combine this planning methods for AFib ablation, let's say, and left atrial appendage occlusion, or are the protocols vastly different?
No, indeed, one could do it. In some cases, we do this in our center. We do pre-procedural CT scans. Number one, to rule out coronary artery disease. Number two, to assess thrombus in the left atrial appendage, so we can also reconstruct it if we wanted to. And then we look at pulmonary vein anatomy to see if the patient is eligible for a single shot ablation device, or we need to go with more flexible devices. Yeah.
All right, I have one more question that came in. There's actually more questions coming in, which is, does slow flow in the atrium change your antiplatelet anticoagulation treatment after left atrial appendage occlusion?
Yep, yes, as we know, we have an indication that a slow flow in the left atrial appendage below 20 centimeters per second is associated with a higher risk of DRTs. There are some data about this. So I would really think about dual antiplatelet therapy in this situation, even if there are more factors for DRTs. Yeah, like permanent atrial fibrillation, large left atrium, for example. Yes. Yeah, I take it into account. Yes.
All right. Another one, maybe, Boris, is on the question of thrombus. If you see thrombus in the left atrial appendage, does this change anything? Do you still see the indication to perform left atrial appendage closure?
Yeah, the official answer is that in the IFU of all devices that I know, the presence of thrombus is a contraindication to perform interventional closure. However, of course, if you look into the literature, there have been case series published where people do implant a device on top of a thrombus. I think the prerequisite for this is that the thrombus is located quite distally inside the LAA and, of course, not in the landing zone. Some people advocate to use cerebral protection devices like the Sentinel, for example, to do these cases. Personally, we have done this in, let's say, 20, 25 cases so far without any thromboembolic complications. So it's feasible, but it should be the last resort of treatment. At first, we at least always try to intensify oral anticoagulation and to resolve the thrombus in a systemic fashion, if possible.
Excellent discussion, because this also covered one of the remaining questions, which was exactly on cerebral protection devices in that specific situation. I think we've answered that. Matthias, do you have additional experience? Are you using Sentinel in these cases?
No,
have you done it?
Yeah, we did cases in the same situation after a prolonged oral anticoagulation. If there's still a thrombus in the distal part of the left atrial appendage, we did several cases and published a series of cases, and we don't use a protection system. And when you look at those series of cases, there's no higher risk in the group of patients where a protection system was not used.
Thank you. We have one more question, time for one more question maybe, and that goes more back to the planning, Boris. That is on, are you using simulation softwares, that kind of softwares that allow you to simulate different devices such as Amulet or Watchman before the procedure? Is there any experience on that?
Personally, I have just a single case experience using these 3D modeling with RTNS, which is a let's say enhanced reality model, but it's not particularly approved for sizing devices or simulate different devices in the anatomy. As I said, I think the value comes with experience. So I guess less experienced people starting their career in the implanting business, they would probably benefit to a larger extent, and others, the benefit is maybe a little less, I suppose.
Especially as we have nicely demonstrated that the success and the efficacy and the safety comes with operator experience. So as we're doing more numbers, it will be difficult to show this added benefit. I'm not saying that this is not valuable. I personally believe the future will be in these kind of simulation studies, but scientifically, it is not easy to prove the added benefit for these kind of devices.
And there's the FEOPS software. There are data that the procedure time is shorter when you use these systems, but I didn't use it either yet.
So let's move on a little bit, because I had initially shown that this webinar is about also showing you potential future indications, and you have heard discussion and seen a case where we have a clear indication, we would say, because of the high bleeding risk, this patient was at urgent need. Now we have patients that eventually don't have so high bleeding risk, but that could also undergo left atrial appendage occlusion. And I'm showing the slide of an observational study, because there is no randomized controlled trial data as yet. There are 2 trials running to test this, but this study recently published shows that patients undergoing left atrial appendage occlusion on top of oral anticoagulation have a lower stroke risk compared to patients that only receive oral anticoagulation. So, Boris, I would really like to get your opinion on this kind of indication. Are you already doing this? Is this future perspective? How do you approach these patients?
I was very happy to see that publication, because it reconfirms what we had already known from our surgical colleagues from LAAC, that the addition of a mechanical stroke prophylaxis adds benefit to systemic anticoagulation. And yes, we are often facing the question, if patients have a stroke on anticoagulation, what to do. And in fact, in addition to this publication, there's an interesting paper published showing that if you switch DOAC therapy to another DOAC or to a vitamin K antagonist, it even gets worse. So the stroke rates are even higher than if you keep your patient on oral anticoagulation that he or she already had. And now here, as clearly shown, additional intervention gives you additional safety. Very important data.
Yes, I agree. And that brings us back to the question, how should these patients be treated? Of course, these are patients that received oral anticoagulation on top of the left atrial appendage occlusion, but it's interesting to see also the antiplatelet treatment. And Matthias, maybe you want to comment on this, because I think it also shows us some very intriguing data.
Yes, I like this data so much because it shows the positive effect that you can reduce stroke rate, and it's not the bleeding issue. But when you look at this data, you would expect that most of the patient would still be on a dual antiplatelet therapy because they had suffered a stroke or even get an oral anticoagulation. But as you can see at the bottom, almost or more than half of the patients get a single antiplatelet therapy or none, and they still have a lower stroke rate than the matched pair comparison patients. So those are really impressive results, and we should also think about the regimen after left atrial appendage occlusion.
Mm-hmm.
And in fact, I think, again, this is very interesting, and maybe the curves would have even separated further if the patients in the occlusion cohort would have continued oral anticoagulation, as in LAAC 3. But this is something we will address with now an ongoing trial, LAAC 4, the first superiority trial for stroke prevention, where patients with persistent atrial fibrillation and a CHA2DS2-VASc score 4 or more will be randomized either into NOAC therapy or to NOAC therapy plus interventional closure, and will be followed for 5 years. And 4,000 patients in more than 200 centers globally. And if we were able to prove that we give additional benefit, this would be a big breakthrough, I think, for this field in medicine.
Yeah, I agree very much. So this is one potential future indication. We'll hear about this. But I'm thrilled also to have you here to present us another potential future indication of concomitant procedures. Please, Boris, go ahead.
Yeah, thanks, Michael. Now we are entering the field of electrophysiology, and as most of you are aware of, there is prospective randomized data from a large trial investigating the question if left atrial appendage closure is equivalent or is non-inferior to continued NOAC therapy after atrial fibrillation ablation. And this study has already been published. In total, 1,600 patients were randomized in a one-to-one fashion to either undergo the combined intervention or a stepwise intervention with the LA closure, or just the ablation with continued NOAC therapy. And to cut it short, here are the results. We were dealing with a primary efficacy endpoint. So the question, does the stroke rate increase? And as you can see from the Kaplan-Meier curves, they are both at the same level with a very low stroke rate in both arms of 0.4% per year in a cohort that had a mean CHA2DS2-VASc score of 3.5. So a very efficient stroke reduction also by catheter ablation, obviously. But the main endpoint was the primary safety endpoint, where ablation plus implantation of a occluder device led to a significant reduction of non-procedure related major bleeding and clinically relevant non-major bleeding. And the reduction was 44%, as you see from the right-sided curve. This was true for both strata, both the concomitant and the sequential cohort of the trial. And that is why I brought this case to you. We treated a 74-year-old male with symptomatic persistent atrial fibrillation at CHA2DS2-VASc of 3 and hematuria on NOAC therapy, normal ejection fraction, mildly enlarged left atrium, and he was scheduled for catheter ablation. We decided to go with a new ablation device. It is a balloon and basket pulse field ablation catheter named Volt. You see it on the left-hand side as a 28 millimeter balloon, which is introduced into the left atrium via a steerable Agilis sheath and is navigated over the wire to the individual pulmonary veins. The balloon, as you can see, is covered with 8 struts. through which you can deploy bipolar pulsed field ablation energy. In the middle picture, you see the electrical field that is deployed in a circular fashion around each pulmonary vein. Just as a note, you could also switch off certain splines so you can deliver focal energy, but for a pulmonary vein, obviously, it's reasonable to go for the full circle. The whole device is navigated in a 3D environment, a very established 3D mapping system, as you see on the right-hand side. And now with the next slide, I will show you the case in high-speed mode. For the sake of time, we accelerated the display. You see the Agilis sheath, the catheter is introduced, and now on the right upper panel, you see the 3D mapping of the left atrium, and we do a map on the fly. So we don't create a map first, but we ablate and map. And you see the balloon is there inflated at the left upper pulmonary vein. The upper circle in blue and white are impedance-based contact markers because contact is important to get a circular or circumferential lesion. And we also wanted to show you on the left upper side that we perform occlusion angiograms through the central lumen of the catheter to assess contact. And as a second step, we can further decrease the inflation status of the balloon to get a more distal ablation lesion inside the tubular portion of the pulmonary vein to really ensure durable pulmonary vein isolation with a single ablation, which is still the most accepted goal in our field. The electrograms on the right lower corner, maybe you don't see them that well, but of course, from all of the splines, we can record local electrograms and we can create activation maps of tachycardias, reentrant tachycardias, for example, and also assess voltage of the left atrium to see the extent of left atrial cardiomyopathy. So now, while I was talking, we completed the complete ablation step, and in the next picture, you see the full lesion set of pulmonary vein isolation. With this strategy of full inflation and partial inflation, we create 2 rings of ablation lesions at each of the 4 pulmonary veins, again, to ensure durable PVI. So after deploying these lesions, we continue in this case with a left atrial appendage closure procedure. For this, we have to exchange the delivery, the steerable Agilis sheath to the amulet delivery sheath over a wire in the left upper pulmonary vein. Then here in the movie, again, high speed, we start with assessing the landing zone. As you can see on the left, we are performing selective LAA angiographies via a pigtail catheter. Now you see it on the right lower pictures, both in an aerial projection, the left one in a cranial and the right one in a caudal angulation, and we determine the landing zone. In parallel, the colleague, the echocardiographer, is doing the same in the 4 standard planes, 0, 45, 90, and 135. And now you saw the red arrow there on the right upper image and the pigtail catheter. And what we find very helpful is that the operator pulls back the pigtail catheter to the presumed landing zone in order to measure at the same level of the left atrial appendage to get the same results. And this, on a regular basis, leads to very consistent results in our lab. Just a small tips and trick at this part. So ultimately, we came up with a landing zone diameter of 18 and 21 millimeters. So we also decided to go with the 25 millimeter amulet device. One point I wanted to show you before we continue with the implantation is that, of course, the energy delivery to the pulmonary venous ridge leads to swelling. And on the left-hand side, you see the pre-procedural TAE of this individual patient. On the right-hand side, you see post-ablation before implantation. And despite the differences in image quality, I think you can appreciate the swelling of the tip of this Coumadin ridge, which is, I think, important to note and to take into account when you do your landing zone assessments in order to prevent peri-device leaks. In fact, this is a relevant problem, as we can learn from this single center observational study in patients that underwent thermal ablation, so cryo or RF as an option, not PFA, but it's very similar, obviously. You see the swelling of the pulmonary venous ridge. You see an implant of a Watchman Flex device here. And on the right lower panel, you see a significant peri-device leak as assessed in CT scan. And in fact, in this observational study, you see that the increase in thickness is almost 3 millimeters on average after ablation. And if you compare on the right-hand side, patients with combined and with standalone LAA closure procedures, the risk for peri-device leak is significantly increased up to 20% have a leak of more than 3 millimeters after a combined procedure. So please take this into consideration, and we can probably discuss maybe some workflow modifications to avoid this. Now let's continue with the device deployment. So you can see the ball-shaped occluder has already been navigated to the LAA. You see the echocardiogram on the left upper, and then the lobe is deployed. And when we are happy with this, we also deploy the disc, unsheath the disc to completely occlude the LAA ostium. What you can see here now is that in the echocardiogram, it appears that the pulmonary venous ridge is not fully covered with the disc. But again, as Matthias Lange has already shown, you can now work on the position of your disc by pulling it out and trying to reposition it on top of the pulmonary venous ridge to completely avoid DRT and also, of course, to cover this swollen pulmonary venous ridge. The final angiogram on the right hand looks very nice. So we were ready to deploy. And if we now continue for the echocardiogram on the left hand side, you see the cable is still attached. The position is ideal. But being very honest with you, of course, sometimes it happens when you then release the cable. You can see that on the right upper TE image, the disc relapses and goes back to the lobe because the tension is too big or the disc is too small, and it won't stay in that position. But still, as you see from the color Doppler, complete occlusion, no peri-device leak so far, and we were quite happy with this result. So I would like to continue with you discussing maybe the space for concomitant procedures. Which patient may we select, or shall we occlude all the patients that we ablate? A lot of work for us. Do you think we need more data beyond option? Do we need data for the amulet device, for different energy modalities? I think that's an interesting question. And then I'm happy to take your question about technical aspects.
Yeah. Thank you very much, first of all, for this very exciting case, because I think that not many people who do these cases, and also not outside of clinical trial environment, probably, because there's also this issue about reimbursement, which we don't want to focus too much today, but it is important in our daily practice. Maybe one question I also have, because you were referring to this issue of swelling once you apply energy during the ablation procedures. One of the issues that were criticized in the early amulet IDE trial was that there was a higher rate of pericardial effusion with amulet, which was thought to be based on the fact that most US operators didn't have a lot of experience by that time with the amulet device, while they had greater experience with the Watchman device. Do you see a risk in general, not so specifically about amulet, but in general, that there will be higher complication rates when you do this in a concomitant procedure?
Yeah, that's a good question. And I think at least there is a positive signal from the SURPASS registry in the United States, where concomitant procedures using the Watchman Flex device, however, were analyzed in comparison to standalone procedures. And the data was presented at HRS 1 year ago, sorry. And it did not show a signal for more effusions, more tamponades, more perforations. So that is quite reassuring. Also in option, the rate of effusion was really low. So the combination of procedures seems to be quite safe. However, indeed, you're right. The Amulet device came up with more perforations or more effusions in the Amulet IDE trial. And I'm quite confident that with the latest or the coming reiteration of the Amulet, changing the stabilizing wires, changing the conformability of the lobe with the next generation Amulet, we will not see that anymore.
Mm-hmm. Very interesting, yeah. Matthias, have you been doing any of these procedures, or
No.
what are your specific thoughts? What do you think? Will this be taken up in the future? Just some perspective from you.
Yes, I'm pretty sure it will be part in the future, especially for the patient with a high risk. I mean, if you have a low CHA2DS2-VASc score of 1 or 2, those are probably not the right candidates. But when you're talking about a high risk for stroke, that means a higher CHA2DS2-VASc score. There's definitely a space for concomitant procedures. But I have one more question about the PFA procedure. Do you expect as many swollen pulmonary ridges as cryoablation or radiofrequency ablation?
Yeah. In the few cases that we did concomitantly, so on a regular basis, of course, we do not do TE imaging during or after the ablation. But in the few cases that we did with PFA, we also saw swelling of the pulmonary venous ridge. So I do not think that the change of energy modality will resolve that issue. However, I would still be thrilled to see another randomized study with PFA, because we could change, for example, the post-implant antithrombotic regimen. In option, it was aspirin plus NOAC therapy for 3 months, which is a quite intense antithrombotic regimen. And we know that with PFA, we do not harm the endothelium that much. We may be able to reduce this post-implant antithrombotic regimen, which would also be another positive factor for our patients.
Definitely.
Yeah. I mean, one of the concerns when we look at our surgical colleagues, one of the concerns of combined procedures or concomitant procedures is always been that, you prolong the duration of the procedure, be it less or more invasive. You maybe have to use more contrast in some, combined procedures. You use more anesthetics. Now, since we're no surgeons, we don't have, oftentimes general anesthesia in these patients applied. Do you think this applies in the same way, or is there only a benefit for combined procedures? Or do you still see the risk of, extending procedure duration in terms of bleeding and all the complications that might occur?
I don't think there's a certain risk doing a concomitant procedure. Probably you will need a little bit more contrast agent, but if the patient has a normal renal function, there's no problem. So I think the issue in Germany, at least, is reimbursement.
Yeah, absolutely.
This is the issue.
Yeah. Let's step back a little bit and really dwell on your proposal. I think it's important to identify patients that benefit from this concomitant procedures. Can you elaborate on this a little bit more, because you have participated also in this trial and you have done these procedures? What are the candidates that you would pick and choose for this procedure?
Yeah, I think that is very important. The entry criterion into the option study was a CHA2DS2-VASc score of 2 or more for male and 3 or more for women. I would not think that we should start with the low-risk patients. So for me, that's personal opinion, the CHA2DS2-VASc of 2 is a natural discriminator. We see very low stroke rates in patients with CHA2DS2-VASc of 1 or 2 after catheter ablation. This has been shown in option. This was shown in a very recent study presented at the ESC from South Korea, where they even stopped oral anticoagulation after ablation. And there will be coming data at AHA, the OCEAN trial, which will probably further add to this understanding. However, in the patient population of 3 and beyond, there remains a considerable risk, and nobody would dare to stop stroke prophylaxis. And I guess that now looking at the data, we certainly can say we reduce the bleeding risk of this individual patient with implanting a device concomitantly. And I would speculate that if we continue the follow-up of these patients, 5 years, 10 years, and we see more therapy adherence failures, and where we see more recurrence of atrial fibrillation, late recurrences, we may even see a signal for less stroke in this patient population. It's a speculation.
Yeah, absolutely. But it's a valid speculation. Now, of course, I think for all of us, it is clear that the effect of reducing bleeding is certainly much stronger than the effect of preventing stroke, because you just have to look at the event rates, bleeding rates versus stroke rates. There's a magnitude of factors in between that is clear. But I would like to see from your daily practice, from your perspective, clinical perspective, how important is it to reduce bleeding in these patients?
Well, it's of course very important to reduce bleeding. You mean in the concomitant
Yes, let's say in those patients that have not so high bleeding risk, that we are, trying to drive through this kind of, this indication expansion to patients that are not excessive risk, and yet they benefit obviously from reducing bleeding events.
I mean, looking at the studies, the benefit from the studies we know is the reduction in a bleeding situation, less complication because of bleeding, and the amount of stroke reduction is the same whether you do oral anticoagulation or implant a left atrial appendage occlusion. So looking at the data we have right now, the reduction of the bleeding risk is the main benefit of the LAAC occlusion device. Mm-hmm. So to answer your question, I always look at the individual bleeding risk of the patient. I look at the history. So this is the main thing to look at when you're thinking about to implant a left atrial appendage occluder.
Yeah. One very specific population, and that is addressed in one of the questions that comes in, is the population of patients with renal failure, maybe even on dialysis. We briefly touched it, but I would like to hear your point of view, Boris. Is this, how important is left atrial appendage occlusion in this particular situation? And maybe are those potential candidates for concomitant procedures in the future?
Yeah. First of all, I think the question is very, very important. We look at the, let's say, sickest population with renal failure, the end-stage patients. They are heavily underrepresented in clinical trials. And we don't know what to do with these patients who are on dialysis. There is some data showing that oral anticoagulation using vitamin K antagonists is even harmful to this patient because they have a high bleeding event rate. Therefore, several studies have been published comparing it to DOAC therapy with, let's say, some positive results, but still disappointingly high rates of bleeding. And so I can only congratulate our friend and colleague Ingo Eitel from Lübeck in Germany, who launched a prospective randomized study in these patients, LA Kidney, to randomize patients to either NOAC or standard clinical care versus LA closure procedure. And I have to say that from all the registry data that others and us collected, there are very positive signals that this therapeutic option is really beneficial in end-stage renal disease patients.
I fully agree. Any other takes, or what is your anticoagulation strategy in these patients? Do you risk to put them on NOAC? Some nephrologists even refer sometimes patients on low-dose NOAC, or do you prefer Coumadin in these patients?
First of all, I agree those are really good candidates for the air occlusion, but nephrologists use apixaban in low-dose regimes, but we have treated pretty many patients on dialysis. I think it's a very good group. Those patients have a high bleeding risk, of course. They have many concomitant morbidities. they are the ideal candidates. I'm really looking forward to the results of this study.
Yeah.
Yeah.
There is one more question which I would like to cover, which is, do you foresee left atrial appendage occlusion moving towards device-specific indications? For example, certain anatomies or patient subgroups where one device clearly outperforms other devices. Do you see this happening in the future? More individual-based medicine, something we dream of, but not really there yet? What's your opinion?
Well, no, I don't foresee that. Let's say the two main players in the field of the LA closure devices have made significant progress in redesigning their device and in making it more conformable for various anatomies. And let's say if you see patients that have failed an implantation attempt, which is already rare, then you might go for the other device to see if that fits better. But in general, now both, let's say, main players cover most of the sizes down from 14 millimeters, or I think even 11 millimeters, to up to 7 millimeters. So I don't think, I couldn't imagine an indication for a specific device type. I don't know.
Yeah.
Your opinion, Matthias?
Same. There are some anatomic situations where we would prefer the one or the other occluder. But I totally agree. In most of the cases, you can use the lobe disc device or the plug device.
I mean, it's a valid question in such that always, you see this improvement coming up, but still we always have to be reflective and criticize ourselves. Can we still do better in the future with endovascular techniques? Now, when I look at surgical techniques, atrial clip, for instance, the surgeons also tend to anticoagulate their patient after the procedure because you have residual leaks, and we come back to the early topic of today. But maybe there is room and space for further developments. I mean, maybe completely different, maybe not even lobe disc devices. There may be other options to completely seal the left atrial appendage in the future, so that we can even further reduce the risk.
The ideal device should not have any DRTs and should not have any peri-device leaks. Yes, that is the goal, I think. Yes,
yeah.
And probably the surface that there's not such a high chance to get a DRT, for example. This is an idea.
Yeah, you talk about activation of the surface to promote endothelialization.
And of course, there are first-in-human trials and also IDE trials and newer approaches. One is a suction device where you suck in and invaginate the left atrial appendage and then ligate it afterwards. I saw cases that were quite convincing, but of course, I could imagine that this adds complexity to the procedure. And we are dreaming of a market where virtually any interventional and any EP colleague can do the intervention because the demand will be so high. So I'm not sure where would be the indication for these, let's say, more complex approaches to the left atrial appendage.
Yeah. Maybe one short question to cover that is still coming in here is, how do you personally deal with patients? So you have you're working in a clinic where you have neurologists on site that refer a lot of patients that had prior stroke. Would you leave them on oral anticoagulation despite? Yes.
Yes.
You would clearly do that, and that's what
we're talking about. A patient who got a stroke under oral anticoagulation. Yes, we do left atrial appendage occlusion, and then we continue the oral anticoagulation the same way, because the only goal is to get a reduction of the stroke risk for the second or even the third stroke, and you don't have a bleeding issue. So we continue the oral anticoagulation.
And from your daily perspective, how frequent do you see these patients? What's the referral for these patients? Just to get a rough understanding.
Yes, it's about one patient per month. In our clinic. Yes.
Boris, you also see these patients, or?
Yeah, we see. I would think that it's about 10% of our current LAA closure population, but we still need to advertise this with our neurological colleagues, which are per se a little more conservative. And of course, we need more data. I think there's also randomized trials ongoing, and I hope they will prove the observational data that you showed earlier.
Yeah. Great. What an amazing discussion. I would like to thank you both so very much for the exciting cases you've shown us. And I think there was a lot of educational content. I repeat that we have shown a first case that shows us more standard contemporary practice in left atrial appendage occlusion with very good tips and tricks what to look for to make this a successful procedure, especially with regards to peri-device leak and device-related thrombosis. We have discussed the post-procedural antithrombotic treatment and pointed out how important it is to really work with the echocardiographer to tell them, exactly what the high-risk thrombus looks like. And we've seen in a fascinating case of future indications of a concomitant procedure with AFib being performed in literally no time that you've shown. And the focus was more on the left atrial appendage occlusion. But there are more new indications to come, which we haven't covered today because it's simply too many. But as an electrophysiologist, there are cases also of electrically isolated left atrial appendage that is coming up, and so on. So many more to come. I would like to thank the audience for joining us this afternoon and for sending in these valuable questions, and hope you enjoyed the session. Thank you very much.
Thank you very much.
Bye-bye.
Bye-bye.